Yes, sir.
Okay.
Yes.
So the drug-induced sleep endoscopy is a diagnostic tool, as you rightly said, to assess the upper way of snorers and obstructive sleep apnea patients in conditions that mimic natural sleep. So we do overnight polysomnography during the natural sleeping time of the patient. Here we are artificially inducing sleep in the patient so that we bring the same scenario like a normal sleep pattern. So it is the utmost importance to understand the upper airway behavior during sleep so that we can make the treatment or plan the treatment for individual patients depending upon the severity of the obstruction. So observation of the upper airway during natural sleep is complicated and impractical in daily practice. So we take indirect measurements like how many times he desaturates, how many times he gets started and then wakes up. So like that we don't see actually the anatomical structures causing the obstruction in OSA when we do polysomnography. Whereas the advantage in drug-induced sleep endoscopy is we are able to locate the exact anatomical location which is responsible for the obstruction. So with the aid of sedation, upper airway can be observed dynamically. That is a very, very important point. That is, the patient is breathing spontaneously, getting obstructed, getting relieved. All these things are observed. So it is called a dynamic observation, and and we know what happens during his natural sleep and what are all the possible treatment options. And it is critical to achieve a sedation level that is resembling natural sleep. So we artificially induce the condition mimicking the natural sleep. So it must be performed where in a dark room where normally people don't have to fall asleep if there is any light or any bright surrounding. So we should give the ideal conditions like the normal sleep environment. So performed in a room where all basic resuscitation equipments are available, and because we are artificially inducing sleep, we should take care that the patient does not go into any respiratory depression or total obstruction and get into a serious state of hypoxemia or other complications. So safety becomes the utmost important, and the room should be quiet and dark to enhance that natural surrounding. So we must have an ECG and a pulse oximeter, which are very, very important, and we should monitor the depth of sleep by bispectral index. So don't say that it may or may not be required. It is a must to assess the depth of sleep. And lighter sedation, as you said, may underestimate the obstruction, or deeper sedation. So it should be ideal sedation. It should mimic natural sleep and produce the same condition as it happens in a patient with OSA. And in children, these values may not be applicable. That's one drawback when you do it in a pediatric patient. And we use the thinnest possible fibroscope with a working channel which can aspirate the secretions. And there must be a recording system of both video to observe the patient's position, is waking up or is but what difference between the polysomnography and this is, here you won't find that patient waking up with a complete obstruction. So as we are seeing all the structures which are causing the obstruction, you won't have that startled wake up and acute desaturation which happens in the normal OSA when you do a polysomnography. But otherwise, you can hear the snoring sound, you can see the vibrations, all that can be seen and recorded. And this is very important. This recording is important because we can replay that and see exactly later on at leisure where exactly the problem is, and then try to correct that particular defect. And if any planning to do any surgery, for example, you can do a palatoplasty, you can do a tonsillectomy, you can do a uvulectomy. All these procedures have been done to improve the upper airway space. So this Dise will be very useful in doing that, which you cannot achieve by polysomnography because we are not seeing any of the structures. And we are using so many drugs, as you rightly said, either alone or in combination. And you can use a TCI pump also. And they have compared natural sleep and TCI propofol sleep, showing what is called the critical closing pressure and the upper airway muscle responsiveness and the apnea hypopnea index. All these things have been recorded and they based on the levels of sedation measured by BIS. And we can even do what is the correct staging of sleep also is very important when you give the drug. And REM sleep cannot be reproduced by propofol sedation. That is one of the drawbacks of this particular investigation tool. And the duration is only short of 15 to 30 minutes. And the snapshot of what happens during the night, it's a small resume of what you get with the overall observation. So instead of observing the patient for 6 to 8 hours, we are able to get all the details that we want within a short time of 15 to 30 minutes. And the TCI propofol pump can produce ideal level of sedation by correctly injecting the dose in a continuous fashion instead of our manually pushing the drug at various doses. And if you add midazolam, maybe we can shorten the duration of the observation window. And the only problem, sometimes it may cause sneezing, making the assessment more difficult. And this is not a painful procedure, so you don't have to spray the nostrils and the nasopharynx when you insert that thin endoscope. So local anesthesia is not necessary. And but when you do it in a pediatric patient, because we don't get extra thin or smaller size pediatric, we actually use the pediatric endoscope for the adult. So it becomes very thin for the adult. But for children, it is not possible. So we have to use nasal decongestant. And patients can be in fully supine or in lateral position also. Those who are used to sleeping in lateral position, that is another point you can add. Assessment in lateral position gives additional information because these patients with established OSA, they normally assume only the lateral position because they don't want to get disturbed by lying supine very frequently. So they adapt themselves to either semi prone or full prone also because the airway becomes more larger in those positions. So you can do it in the lateral position also. It is not necessary that you should do it only in supine, but in supine you will get the you can find out the maximum obstruction that is happening. And it is very common for patients to open their mouth during Dise as they do. So you would have seen some of the patients with obstruction, especially children with big adenoids. They have that classical adenoid faces. Their mouth will be always open, the tongue will be partially protruding, and they develop buck teeth also because of all that. So the same thing can happen in adults also. They keep their mouth open and prevent the tongue going backward, pushing the soft palate. And this same maneuver can be done by us by pulling the chin forward, which is called S-mark maneuver. So this is how you do that. If the patient goes in for obstruction and if you are doing this procedure in supine position, you can slightly remove that obstruction by pulling this jaw forward. So this is different from the chin lift, where we give the thrust from the angle of the mandible. So here we are pulling it at the mentum level, at the lower incisor level. We hold the mandible and pull it forward. So it is slightly different. So it is not full jaw thrust as we do with the chinlet. So it will not completely remove the obstruction to give a false positive normal airway. So we must do only this maneuver if there is an obstruction. So it is better to begin with observation of the upper airway part to see the soft palate and how it closes. And then the tongue base and epiglottis should collapse while the palate is open. This is the normal thing that may happen. And sometimes you may not be able to see the tongue base or epiglottis as the soft palate is closed. So these are all the observations which we should know what to look for. And after observing the soft palate over 1 to 2 minutes, the scope can be advanced downward to observe the other parts of the upper airway. And we can proceed with all these maneuvers. And taking too much time is not useful because all these inspections can be finished in a very short way as you are entering. That is why you said the whole process can be finished within 15 to 30 minutes. UA will be full of saliva due to inhibition of deglutition when you artificially induce that. But in natural sleep, most of us do not secrete so much of saliva. The OSA patients do not secrete, whereas this maneuver, this inserting the scope, all these things can stimulate salivation, and with the propofol suppressing the deglutition or swallowing, the accumulation of saliva will happen. And the event must be observed for the areas of vibration as well as for collapse. So these are the two things that you are going to observe. And this picture is just for you to understand what are all the various ways in which you can see. And you can see the details are given here. In the first picture, you can see this is the soft palate and tongue, which is closing like a transverse velum lateral. This is called velum lateral. And this is velum AP view. And this is B is velum lateral. C is velum circular. It is almost like a round, whereas here it is like a slit, vertical slit. And D shows oropharynx in the lateral. And then E is the tongue base, the lymphoid tissue. And F is the tongue base lateral, not like a opens like a book. And G is the tongue base, which is concentric. And there is an AP movement of the tongue, and the lateral walls also contribute to the collapse. And H, epiglottis AP, that is anteroposterior, and I is epiglottic lateral. So it folds like this. So these are all the various views you can see. And of course, the video will automatically be recorded. So you can replay these things and see what type of occlusion that is happening. And based on this only, you decide what is the treatment that you are going to give. And as you mentioned, patients who are unable to tolerate CPAP, Dise will decide what type of treatment we can give. And also, if they, in spite of tolerating CPAP, if it is not able to relieve the obstruction and CPAP failure happens, that also can be diagnosed by doing the Dise. And this is what is called the modified Vogt classification, where you inspect the velum, oropharyngeal walls, tongue base, and epiglottis. These four structures we are going to observe. And if you take the first letter of all these things, you get that acronym Vogt: velum, oropharynx, tongue, and epiglottis. And based on three configurations, you can have to see whether it is an anteroposterior or lateral or circular. And then based on that, we can observe the degree of obstruction. And the contraindications are, if the patient belongs to ASA class 4, very morbidly sick patient, or pregnancy, or allergy to any of the drugs, are all the contraindications. And if the patient by previous overnight polysomnography has got a high apnea hypopnea index, that is not at all a contraindication for Dise. You can do that. And what are all the things that will be reported when you give the result of the drug-induced sleep endoscopy? You have to mention what is the level of sedation that was given, you must mention what was the lowest oxygen saturation recorded during the procedure, and you must you tell what are all the drugs that were used for sedation, including whether it was a manual bolus and intermittent doses or using a TCI pump. So the delivery mode and the sedation target level achieved, and what are all the upper airway findings and maneuvers performed. If there is any obstruction like SMAR maneuver, you have to mention that also. So this is how the final report will be given, based giving these 5 points: the level of sedation, lowest SpO2, drugs used and the mode of delivery, upper airway findings, and any maneuvers performed during the Dise. Okay? So that completes the answer. And if you write it in this way, it will be, you will be able to complete the answer also within the given time. Okay? So